Ever get that feeling like your heart's just, I don't know, working a bit too hard? Maybe you're feeling breathless sometimes or just tired.
Hmm?
Well, today we're diving into something called aortic regurgitation. It's a situation where the heart definitely has some extra work on its plate.
Yeah, exactly. Aortic regurgitation, or AR, we often call it that. Uh, Put simply, it's like the main door leading out of your heart, the aortic valve. It doesn't shut properly.
Like a leaky door.
Precisely. So imagine blood's just been pumped out to the body, right, through this valve, this one-way street. But because it's leaky, some of that blood flows backward,
Ah, okay, back into the heart.
back into the main pumping chamber, the left ventricle, yeah. During the heart's rest phase, diastole, it's like traffic going the wrong way on that one-way street.
Yeah.
Causes a bit of a backup.
That makes sense. That faulty gate analogy really clarifies it. All that backflow puts extra strain on the starting point, the left ventricle.
It certainly does.
So for this deep dive, let's really unpack what's happening with this leak, figure out why it happens and what can actually be done about it.
Okay, so the core issue is that backward leak during diastole, when the heart's relaxing. Normally, the aortic valve has three little flaps, cusps we call them.
Good cusps, right?
They should seal perfectly. In AR, they just don't.
Yeah.
They don't meet tightly. And what happens then is, well, this backflow increases the amount of blood, the volume, and the pressure inside that left ventricle.
Okay, more volume, more pressure.
Yeah, and think about your heart muscle like, say, your bicep. If you work it harder, it gets bigger, right?
Right, hypertrophy.
Exactly, hypertrophy.
Yeah.
The left ventricle enlarges, it bulks up to try and handle this extra load and keep pumping enough blood out.
Yeah.
But, unlike your bicep getting stronger being good,
A bigger heart isn't always better.
not necessarily. Over time, this stretched, enlarged heart can actually become less efficient. It struggles.
Okay, so the heart tries to compensate, but it's a temporary fix, potentially. What actually causes the valve to get leaky like that in the first place? What are the root causes?
Well, we can sort of group the causes into two main buckets. Either there's a problem with the valve leaflets themselves, or there's an issue with the aortic root.
The root, what's that part?
That's the first section of the aorta, the big artery leaving the heart where the valve is actually attached.
Gotcha. So valve problems first.
Okay, yeah, valve problems. Worldwide, the biggest culprit is actually rheumatic fever.
Rheumatic fever. Okay.
Yeah, you can maybe remember RHE rheumatic can wreck the valves. Then there's a condition you're born with, a bicuspid aortic valve.
Bicuspid, meaning two cusps instead of three.
Exactly. Bi for two. Normally three, you're just two. That can lead to problems. Then infective endocarditis, that's a nasty infection on the heart valve itself.
An infection, right.
And finally, something called calcific valve disease. Think calcified, like calcium buildup. It's sort of age-related wear and tear on the valve.
Okay, so rheumatic fever, bicuspid valve, infection, and wear and tear. Makes sense. What about the other bucket, the aortic root problems?
Right, the aortic root. Often the issue here is that the root itself gets stretched out, dilated. Chronic high blood pressure, hypertension can do that over time.
Just the constant pressure.
Yeah, it weakens the aortic wall.
Yeah.
Also, certain genetic conditions affecting connective tissue like Marfan syndrome or Ehlers-Danlos syndrome. People with Marfans are often tall and thin,
I've heard of those. They affect tissue strength.
Exactly. They weaken the structures,
Yeah.
including the aorta.
Yeah.
Less common now, but syphilis, specifically syphilitic aortitis, could damage the aorta.
Wow, okay.
And then there are inflammatory conditions, things called spondyloarthropathies. Think ankylosing spondylitis or psoriatic arthropathy. Sometimes they affect the aorta.
Inflammation causing problems there too.
Yeah. And finally, direct physical causes like major chest trauma or an aortic dissection. That's a tear in the aorta wall, which is a medical emergency and can cause sudden severe AR.
A tear, right. Very serious.
And interestingly, that bicuspid valve we mentioned, having one can actually increase the risk for problems in both the valve leaflets and the aortic root. It's kind of a double whammy sometimes.
So it pops up in both categories.
Right.
Okay,
Yeah.
quite a range of causes. Now, who should be particularly aware? Who's more at risk of developing this?
Well, the risk factors really mirror the causes we just went through.
Yeah.
So definitely getting older increases risk. High blood pressure is a big one.
Hypertension, yeah.
A past history of rheumatic fever, obviously.
Mm-hmm.
Being born with that bicuspid aortic valve.
Yeah.
Having had infective endocarditis before.
Right, the infection again.
And then those connective tissue disorders, Marfan, Ehlers-Danlos type IV, even Turner syndrome. And the inflammatory ones like ankylosing spondylitis, reactive arthritis, Takayasu's, Besset's disease, SLE as well.
A long list.
It is. And just to flag again, the really critical causes of acute Severe AR, the ones needing immediate attention, think INA.
INA.
Infective endocarditis and aortic dissection. Those are emergencies.
Got it. I and A for acute severe. Okay, so we know what it is, why it happens, who's at risk. How would someone actually know they might have it? What does it feel like?
That's key. Because early on, honestly, many people feel absolutely nothing. It can be totally asymptomatic.
No symptoms at all.
Often, yes. But as the leak gets worse, or the heart starts to struggle, then symptoms can creep in. Things like feeling really tired, fatigue, getting short of breath, especially with activity that's dyspnea.
Okay, breathlessness.
Palpitations, like feeling your heart race or skip beats, sometimes chest pain, angina. And a really specific one is orthopnea, finding it hard to breathe when you lie down flat.
Having to prop yourself up with pillows.
Exactly. You might also see signs of the heart struggling to cope with the fluid volume. Swelling in the legs or ankles, that's peripheral edema. Fluid in the lungs, pulmonary edema, even swollen neck veins, jugular venous distension.
So those are things the person might notice. What about a doctor? What clues might they find during an exam?
Good question. During the physical exam, listening to the heart is obviously crucial. We might hear the first heart sound, S1, being a bit softer than usual.
Soft S1.
But the classic finding is a heart murmur. Specifically, an early diastolic murmur. It's often this blowing sound heard best when you lean forward and breathe all the way out.
Okay, lean forward, breathe out,
Yeah.
specific.
Yeah. And if the AR is quite severe, you might also hear another murmur later in diastole, called an Austin Flint murmur.
Austin Flint.
Yeah. Now here's a useful tip for exams, or just understanding. Unlike the murmur in aortic stenosis, where the valve is tight.
Right, stenosis is narrowing.
Exactly. Unlike that murmur, the AR murmur typically doesn't radiate up into the carotid arteries in the neck. That helps tell them apart.
Ah, good distinction. Doesn't travel to the neck.
Right. And one other thing, if the cause is infective endocarditis, the murmur might sound a bit different, maybe more musical or rough.
Interesting. Okay, so murmurs are key. Any other physical signs?
Definitely. Feeling the pulse is very informative. You can get what's called a collapsing pulse.
Collapse.
No, it feels like it shoots up really fast and then it just drops away quickly. It's also sometimes called a water hammer pulse, though that term is used a bit less now.
Water hammer pulse, okay.
And related to that, you often find a wide pulse pressure. That's a big gap between the top number, systolic, and the bottom number, diastolic, on a blood pressure reading. The diastolic pressure itself might be quite low.
Wide gap, low bottom number.
And sometimes you can actually see exaggerated pulsing in the arteries. Maybe even though it's rarer now, Corrigan's sign, where the carotid pulses are really bounding, or even de Musset's sign.
What's that?
That's where the person's head actually bobs slightly with each heartbeat. It's quite striking, but again, usually seen in very severe, often untreated cases.
Head bobbing, wow.
And one more, quite fascinating one, is Quincke's sign. You might see tiny pulsations in the nail beds if you press lightly on the nail.
Pulsing nail beds. Amazing detail.
It is. And very rarely, in an emergency situation, like if a valve cusp tears completely, you might hear this bizarre cooing dove sound over the heart. That signals a catastrophic valve failure.
Cooing dove. Okay, hopefully not something heard often. So, lots of potential clues there. If a doctor suspects AR based on these signs, what tests confirm it and show how bad it is?
The absolute cornerstone, the main test, is an echocardiogram, usually a transthoracic echo, the ultrasound gel on the chest type.
Echo, right. Standard heart ultrasound.
Exactly. It's fantastic. It lets us see the valve, see the leak, quantify how much blood is flowing backward, look for the cause like a bicuspid valve or thickened leaflets, and critically, see how the left ventricles is coping. Is it enlarged? Is it pumping well?
Gives you the whole picture.
Pretty much. Sometimes a cardiac MRI is really helpful, especially for looking closely at the aorta itself, the size of the aortic root, checking for any dissection or aneurysm.
MRI for the big picture of the aorta.
Yes. An ECG, electrocardiogram, is standard too. It might show signs the left ventricle is enlarged, that hypertrophy we talked about, or pick up arrhythmias or electrical conduction problems.
ECG for electrical activity.
Right. And in certain cases, maybe before surgery, a cardiac catheterization might be done, going in with thin tubes to measure pressures directly inside the heart and check the coronary arteries for blockages.
Cath lab, okay. More invasive.
A bit more invasive, yeah. Not always needed for diagnosis, but sometimes for planning treatment. And a simple chest x-ray can sometimes show if the heart is enlarged or if there are signs of fluid in the lungs suggesting heart failure.
Okay, so echo is key, maybe MRI, ECG, sometimes cath, chest x-ray.
Got it.
Got it. So once it's diagnosed, what's the plan? How do you manage aortic regurgitation?
Well, it really hinges on two things. How severe is the leak, and is the person having symptoms?
Severity and symptoms. Makes sense.
For medical management, if needed, we use medications. Things like vasodilators, ACE inhibitors are common examples. They relax blood vessels, making it easier for the heart to pump blood forward, reducing the backflow a bit.
Less resistance.
Exactly. Diuretics like furosemide can help if there's fluid buildup, that edema. And sometimes beta blockers are used, especially if there's an underlying condition like Marfan syndrome, to reduce stress on the aorta and slow the heart rate.
Okay, meds can help manage things. But what about fixing the valve itself? When is surgery needed?
Surgery is often the definitive treatment, especially for severe AR. The main options are either repairing the patient's own valve, if possible, or replacing it entirely with an artificial one, mechanical or biological.
Repair or replace?
Yeah. In some specialized centers, particularly for younger patients with mainly an aortic root problem but a decent valve, they might do a valve-sparing aortic root replacement. They replace the root, but reimplant the patient's own valves.
Oh, interesting. Saving the original valve.
If possible, yeah. The more standard operation, though, might involve replacing both the root and the valve together, often as a composite graft, and then reattaching the coronary arteries.
Okay. What about those newer, less invasive valve procedures like TVI?
TVI, transcatheter aortic valve implantation. It's used a lot for aortic stenosis, but for pure aortic regurgitation, it's generally not the first choice if someone is a suitable candidate for open heart surgery, especially if they're low or intermediate risk.
Mm-hmm.
The outcomes aren't quite as established yet for AR compared to surgery.
Ah, okay. So surgery is still the mainstay for severe AR needing intervention. How about follow-up? How often do people need checking?
Regular monitoring is vital. If you have mild or moderate AR and no symptoms, usually a checkup once a year and an echo every couple years is enough.
Yearly checks, echo every 2 years for mild moderate.
Right. But if it's severe AR, even without symptoms, you need closer watching, maybe more frequent echoes initially, then usually yearly once stable. And definitely if the aorta is dilated, like in Marfan's, that needs at least yearly echo checks. And sometimes CT or MRI scans, too, to track the size.
Closer watch for severe cases or dilated aorta?
Absolutely. And just to add, those medications we talked about, like vasodilators, they can be crucial short-term if someone develops severe heart failure, sort of bridging them to surgery. Long-term ACE inhibitors, or ARBs, are often used if someone has chronic severe AR with heart failure symptoms or high blood pressure.
Okay. So when do you actually pull the trigger for surgery? What are the main reasons?
The big indications are, 1, if the patient develops symptoms related to the AR, breathlessness, chest pain, etc., that's usually a clear sign to operate.
Symptoms mean surgery.
Generally, yes. And 2, even if someone feels fine, if we see evidence that the left ventricle is starting to fail specifically, if the ejection fraction, that measure of pumping strength, drops below 55%.
VEF less than 55%.
Exactly. Or if the left ventricle just gets too dilated, or if the aorta itself becomes significantly enlarged, usually over 50 or 55 millimeters, depending on the context, those are signs the heart is under too much strain, even without symptoms. And surgery is needed to prevent irreversible damage.
So symptoms or objective signs of the heart struggling or the aorta getting too big, that makes sense. Looking at the bigger picture then, what's the overall outlook for someone with AR? What's the prognosis like?
The prognosis really depends heavily on how severe it is, whether there are symptoms, and crucially, whether it's diagnosed and managed effectively and on time.
Timely management is key.
Hugely key. With the right treatment, especially surgery when indicated, the long-term outlook can actually be quite good. Many people live normal, active lives.
That's reassuring.
It is. However, if severe AR is left untreated, or if treatment is delayed too long, the prognosis is definitely poorer. It can lead to progressive heart failure, dangerous arrhythmias, and ultimately increase the risk of death.
So ignoring it is not an option.
Absolutely not. Acute severe AR, like from that aortic dissection or endocarditis, is life-threatening without urgent intervention. And chronic severe AR, once it starts causing significant symptoms, also carries a poor prognosis if not surgically corrected, mainly because the left ventricle damage can become permanent.
That ventricle damage seems critical.
It really is. And certain things point towards worse outcomes, like how large the aortic root diameter gets, and sometimes a family history of aortic dissection or sudden death can be a red flag too.
Family history matters too.
It can. And just to put a number on it, for people with severe symptomatic AR who don't get surgery, The mortality rate is estimated to be quite high, maybe around 10 to 20% per year.
Wow, 10–20% per year. That really drives home the need for treatment.
It really does.
And if things aren't managed well, what are the main complications we worry about?
The big ones stem from that chronic volume overload and heart strain. So heart failure is the number one. Angina, that chest pain, various cardiac arrhythmias, irregular heartbeat.
Arrhythmias, yeah.
There's also an increased risk of getting infective endocarditis on the already damaged valve. Aortic dissection, especially if the root is dilated. And sadly, in some cases, sudden cardiac death.
A serious list. Heart failure, angina, arrhythmias, infection, dissection, sudden death.
Yes. Underlines why proper management is so important.
Absolutely. So wrapping this up, the main takeaway seems to be that aortic regurgitation, this leaky valve situation, definitely puts extra strain on the heart. But the good news is, with awareness, knowing the potential symptoms, getting diagnosed properly, especially with echocardiography, and getting timely treatment, whether that's medication or surgery.
Yeah, the outlook is generally positive.
It really highlights being proactive about your health, doesn't it? Listening to your body, getting checked out if things don't feel right, especially if you have known risk factors.
Couldn't agree more. Understanding the signs, knowing the risks, and following up with healthcare providers is just paramount for heart health overall.
Well said. And if you, our listeners, want to dive even deeper into medical topics like aortic regurgitation or prepare for exams, definitely check out pastthemsra.com.
And freemsra.com also has some great resources available.
Excellent resources for learning. Thanks for joining us on this deep dive today.